right. Good afternoon, everybody. So, as Mercier just said, I'm from France, as you can hear probably from my accent. So my name is Greg. I'm a physician by training, a public health physician. Then I went into data and data analytics, and I'm now head of the data science unit at Montpellier University Hospital. And so basically, what is the kind of job we are doing in a hospital-based data science unit? So we are in charge of the hospital data warehouse, mostly. So all questions around reusing data to do research, but also to do some innovation to develop new products, and also how to link the local in-hospital data warehouse with different external data sources. So that's our job. So today I'm going to focus on the hospital data warehouse and give you, share thoughts with you about some opportunities, but also challenges. And specifically, I'm going to share with you a use case, which is how we can use this hospital data warehouse to develop new tools, actually innovations. So very briefly, an introduction to the context. So Montpellier Teaching Hospital is the 6th hospital in France by size. It's around 11,000 professionals. And so each year, 235,000 patients are admitted. 57% of them being admitted as a day admission, so short stays, 34% inpatient, and then 9% hospital at home. So it's just to give you an overview of the size of the hospital and also of the type of activity. Then if we come to specifically to the hospital data warehouse, again, some figures, and then I'm going to stop with figures, I promise. So on the right, you have the quantitative description of the data warehouse as it is today. And then on the left part of the slide, you have the qualitative description and specifically a list of the variables of the data which is currently available in the hospital warehouse. So starting from the left, if you consider a patient, if you consider a hospital admission or even a visit, so everything is going to be in the hospital data warehouse in a structured way. So that means history and current diagnosis, but also signs and symptoms, laboratory tests, inpatient drugs and medical devices. So if they are used inside the hospital during the stay, all medical and surgical procedures. And then also you have information about emergency room visits, outpatient visits, and of course, inpatient admissions. Then some specific questionnaires, typically quality of life questionnaires such as EQ5D are now implemented in the hospital warehouse, and also claims data. So we have a DRG-based financing system in France, very similar to actually all most countries in the world. And so we also have this claims data being part of the hospital data warehouse at the patient level, which means that you have costs, for instance. And in addition to this structured data, we also have a lot of text documents. So from the hospital physicians, but also typically from the GP of the patients. So some of them coming from the outside, but they are in the warehouse as text documents. So they are typically unstructured. In terms of some quantitative information about the warehouse, so it is covering now 2.3 million patients So it means that it's an incremental coverage, of course, obviously. And so it means that 2.3 million people have been in contact with the hospital at least once in the last, let's say, 9 or almost 10 years now. All right. And of course, we have a unique patient ID, so we are able to trace back all the contacts over the last decade. So in terms of structured elements, it's well above 250 million elements, so covering all the content on the left panel. We also have more than 33 million text documents, and it's a specific richness, but also it comes with specific challenges, as you know. And if we focus on hospital admissions, so it's around 15 million hospital admissions in total, so over more than 10 years again. And then in terms of format and data standard, we are aligning, so we are not totally aligned, to be honest today, with the OMOP common data model, but we are, let's say, getting aligned. So we should be fully aligned in the coming year. So it has been a huge project. So this being said, I'm not going to give you more figures and more details about the hospital data warehouse, but I want to focus on a use case, which is about patients with chronic heart failure. So one of the leading causes of death, but also of cost to the healthcare systems around the world. And so there is a specific pain point when we consider patients with chronic heart failure. It's the risk or the probability of being readmitted. So actually being admitted to a hospital several times over the time. It could be once a year. It could be, for the most severe patients, once a month, and sometimes even more frequently. So it's obviously a huge problem to the payers. It's a huge also problem to the patients, because each time a patient is admitted to the hospital, so it's, of course, an opportunity to get treated, but it's also a risk, especially for very old patients. And so there is a specific question, which is, how can we know, how can we predict the readmission risk at the patient level? And so the project, the use case I'm going to show you from now is all about using the hospital data warehouse to predict the risk of readmission of all patients with chronic heart failure. So if we come back to the Montpellier Hospital context, we are talking about around 2,000 to 2,000 patients currently diagnosed with a chronic heart failure. And so all those patients are at risk of readmissions, but of course there is a different level of risk according to the patient. Each patient is different, but still we can find some patterns. And so the thing when you talk to the cardiologist is that if they would be able to identify, let's say, the top 20% patients in terms of readmission risks, then they would be able to implement specific decisions, specific interventions. It could be a home-based, for instance, surveillance or follow-up. It could be also what they call now a preventive visit, or even a preventive hospital admission. So it means that you decide to admit the patient before the severity of the disease is too problematic. So that's the point about being able to predict an individual risk score and then integrate this risk in the medical decision-making process, so at the patient level. So it's a very simplistic view, but the current, so that's the the upper part of the slide, the current way to manage patients is that once the patient is admitted, it's in the hospital, there is, of course, a decision which is already very complex based on lots of medical data, and then there is a decision on the best treatment according to the patient, but there is a high risk of readmission. The cumulative readmission risk is around 25% over 1 year, so it's actually very high. And so the whole point of the project is to be able to improve the decision-making by including the risk score, which is a summary of several dozens of different variables. And so to be able to decide a targeted, a personalized treatment plan for the patient, and then ideally reduce the readmission risk of the patient. So I'm not going to go into the technical details, but because it's not the point, but it's based on 3 components. The first component is extracting data. So from different sources, most of them being inside the hospital data warehouse. So all the clinical data, the biology, the drugs, and also the claims data. So the patient history in terms of hospital admissions, but also in terms of visits in the hospital, and also some very specific information which are extracted from the text, so the unstructured text documents. And I'm going to give you a single example, which is the smoking status. So is the patient a smoker at the time of admission? It's a really powerful predictor, but it's actually available only in the text documents today. So then there is a predictive part, which is an AI component. And again, I'm not going to tell you more because it's not the purpose. And then there is also a risk score calculation, which is then incorporated into the hospital software. And so all of this is included in a software which is going to be considered as a medical device, because it has the ability to change the treatment plan at the patient level. So it's ongoing, but it's probably going to be a class 2A medical device according to the European regulation. And so this being said, I'm going to focus on 3 specific questions, 3 specific issues actually around the use of hospital data warehouse to develop such an innovation. The first point is about integration, and I'm going to explain just after the slide what I'm talking about. The second one is interoperability. So how do you tackle this specific, very important point of interoperability from the beginning of the project? And then I'm going to address also several related topics such as usability, transparency, trust, explainability, and so on. And so I'm going now in the second part of my presentation to actually share with you how concretely we did.
Greg, sorry, sometimes
yes.
there's connection of your microphone. I don't know why. Sometimes.
Oh, is it working now?
Yes, it's fine. Thanks.
I'm sorry.
No problem.
All right. Feel free to let me know if there is a problem. I was saying, so the first point is the topic of the integration of the prediction tool in the hospital ecosystem. So and in particular in the physician's workflow. So if you come back to the whole question is about how to make the use of this predictive tool as easy as possible, to put it simple, from the physician perspective, because the user is the physician. So we identified 3 different points. The first point, starting on the right, is of course to integrate the risk score directly into the physician's workflow. The second point is to help, and we actually identified this very specific point by doing focus groups with cardiologists. And actually there is a specific point which is providing them with a basic, let's say, knowledge about statistics. And you're going to see what I mean right after. And also to help the physician understand the drivers. So it's related to explainability and transparency. But the key point is that if there is a red light, the cardiologist wants to know why there is this red light for this very specific patient. So if we dig deeper, into these three concepts. So the first one is the understanding of the drivers. So it's about the explainability and also to help the cardiologist understand the specific factors, so the specific variables which are increasing or decreasing the value of the score. So it has a lot to do with the way you analyze and the way you build and you run and even you choose the models. And it's actually not a new concept, but the more transparent you are in the way you build and you analyze the data, then the easier it is for the cardiologist to understand. The second point is the integration in the physician's workflow. So there is a well-known problem in actually all around the world. You know that the average physician spends an estimated 30 to 40% of her time actually not seeing patients, but seeing a computer screen. And so, of course, we don't want the physician to have to connect to a specific platform on the web to get the score. It has to be integrated by design in the existing software. So, of course, depending on the context, the software might be different, but it has to be integrated. And then there is an obvious link with interoperability. And also, at the end, there is the question of the training for physicians, for cardiologists, just because if we think about the first part of the slide, if we want them to be able to understand the drivers and the predictors, they need, of course, to have a background in basic statistics. The second point is about interoperability. So interoperability is a well-known component of all data actually projects in the healthcare sector, and there is this very well-known Nature Digital Medicine paper explaining why actually we have to put interoperability first if we think about digital medicine, generally speaking. So you know the definition, but it's about exchanging information in an easy and useful way. And specifically in the healthcare sector, it means usually using specifics, data storage, and also data exchange standards. So back to the project, to the prediction projects, what we decided actually, concretely speaking, is actually a three-part.
The same problem, Greg, with this microphone. Probably using normal notebook microphone would be better than this Bluetooth system.
Is it better like this?
Yeah, it's better. Technology is not always the best. Yes.
I'm sorry.
No problem. Thanks.
All right. Yes. So we had a three-part plan. The first plan is to when it was feasible, when they exist, to use existing data standards. So typically OMOP and the terminologies coming with the data standards. So for instance, we by design we developed the tool based on SNOMED CT data for all diagnoses, typically. Then there is the question of the algorithm. So the question of the point I mentioned earlier, which is how do you choose a model, and also how do you develop the model, how do you select variables, and how do you make the contribution of each variable to the decision, to the risk score, understandable to the end user. And so, as you know, it can be easier if you use standard statistical models, and it can be more challenging if you use machine learning tools. But in any case, you have to keep this in mind, and you have to use the best guidelines to improve the understandability. And then, generally speaking, you also have to increase the transparency. And so, concretely speaking, when we started to develop the tool, we had a board of physicians, we had a scientific committee, and so one of the first actually topic that we addressed with the scientific board was the question of how do they understand, how do they define transparency and explicability in their field in terms of predictive medicine. So, and that was very useful then back to the development process to make decisions about how do we explain the development process. So that's just to show the obvious, which is that it's a complex, very complex field. And then the third topic I wanted to address is actually a group of several topics. They are all different, but they are all interrelated. It's about trustworthiness, explainability, usability, and also transparency. So it's partly related to the previous part, but it's also a specific field, really about trust, actually. And so again, I'm just going to share with you how did we, in a way, manage to improve our development plan regarding to these aspects. So in terms of trustworthiness, the starting point is the data. So that's why I started with describing the hospital data warehouse, because it's actually, if you want the end user to trust your tool, you have to explain how it is, I mean, what the data source is. In terms of explainability, I already addressed this in the previous slide, and so I think I have to move a little bit faster, but I'm almost done now.
We have 2 minutes, please. Thanks a lot.
Sorry?
We have 2 minutes left.
Okay, so that's perfect. I will be on time. In terms of usability, so it's starting before the development, because if you want to perfectly incorporate the predictive tool in the clinical workflow, you first have to understand and to analyze the current clinical workflow. And also you have to understand how the data is generated along the patient pathway, the patient journey, and then how this data is is added into the hospital data warehouse, and so then how you're going to use this specific data. So actually you have to understand how the clinical workflow and how the hospital data warehouse are integrated in terms of data flow. And then if you think about the prediction tool, it is also itself generating new data, and typically the risk score is a new data which is generated by the algorithm. And so we, for instance, we designed the tool so that it is also embedding the risk score in the hospital data warehouse. So it's actually a double way integration in terms of data. The prediction tool is based on the hospital data warehouse, and it's also generating new data. And so the last point is about transparency and specifically fairness. And so fairness is about mostly about actually eliciting and controlling biases in the development of algorithms. And so I'm just going to give you an example because it's a very conceptual point, but we had a very important discussion with the end user, so with the cardiologist, which is the fact that if you consider the fact that some patients live in remote areas, so they might have difficulties just to access the hospital or even to access a GP or a family physician. And so you might have less information about those patients. And because you have less information, you might consider, for instance, that they have less comorbidities just because you have less data. And so you think they have less comorbidities. But it's actually just the fact that because they live in remote areas, they have less contacts with the healthcare system. And so there is, in a way, a smaller quantity of data about those patients. And so there is no easy fix to this problem, but we at least identified the problem that the prediction tool might be less powerful for those specific patients living in remote areas and having less contacts with the healthcare system compared to the rest of the patient population.
Yeah, Greg, sorry to interrupt you. I apologize. We are just running out of time.
Yes, but you know what? It's actually the conclusion. So yes. I'm done. And I think the conclusion is that, well, of course, it's a very good opportunity to develop patient-level predictive tools. And you have to anticipate actually everything that I went through. Thank you very much.
Okay, thanks a lot. I apologize. It's so difficult. It's online. We cannot give time. We will get into